All right, let's get started. Go ahead.
All right, hi everyone. Hi, I have a few announcements before we get started. First of all, thank you all for bearing with me as we went through sectioning, which as you can imagine is hard in such a large course. We had to make some changes, but I think everyone now should be in a section. If you're not, please email me. If you're in a Monday section, I've gotten a few emails about what's going on with President's Day next week. Your TFs will be in touch with you, so talk to them. One other thing, if you have an AEO letter, then I sent you, and you gave me a copy, then I sent you an email this weekend confirming that we will be accommodating you. If you didn't get an email like that, then I don't have a letter from you, and you should come talk to me after class. And finally, there are about 20 of you in here who have sectioned but have not turned in a form to actually enroll in the class. Please do that right away. Thank you.
Every year we have a few students who actually live the nightmare that we all had. You know, like you guys ever had this nightmare where you dreamed that you screwed up your paperwork and you enrolled in a class that you never attended? Then you have to take the exam and you've never attended? Anyone have this sound familiar? This was my kind of nightmare. Anyway. Okay. Are there any questions on the material so far? Is this volume working okay for, yeah? Any questions on the material so far? All right, last time we discussed, also, raise your hands if you got that disease category exercise. Okay, if you haven't completed it, please complete it right away. And Gabe, wherever you are, if you could just make sure that I get by next lecture, I think I need the data. All right, so last time we discussed ways of measuring socioeconomic status and the variation in life expectancy according to socioeconomic status. We talked about ways that health and socioeconomic status could be causally interrelated, with SES causing health and health causing SES. We reviewed possible mechanisms for both directions of this effect, including such things as risk behaviors, access to health care, and reduced earnings during illness, or due to illness. We considered the fact that the directionality of the relationship could change across the life course. And we examined some new ideas about how socioeconomic status might affect health, including ideas about relative position in the social hierarchy and the problem of in utero exposures. And we close with some remarks on the idea of fundamental causes in the social sciences. And this is a very important idea we're going to return to. But I'd like to return to another idea we introduced at the end of the last class on the natural and the social lotteries. Here's an excerpt from a letter that Thomas Jefferson sent to John Adams in 1813. Jefferson, incidentally, was just an unbelievably brilliant human being. And there's a very famous remark about him, which President Kennedy made at some kind of very famous event in which he invited all the then living Nobel laureates in the United States to the White House for a dinner. And in his remarks, he said, here we have assembled, some of the greatest minds in the United States that have ever come together in the White House, with the possible exception of when Thomas Jefferson dined alone. And truly, Jefferson was unbelievable. Anyway, so here's what Jefferson writes to a letter to Adams in 1813. For I agree with you that there is a natural aristocracy among men. The grounds of this are virtue and talents. Formerly, bodily powers gave place among the aristi. But since the invention of gunpowder has armed the weak as well as the strong with missile death, bodily strength, like beauty, good humor, politeness, and other accomplishments, has become but an auxiliary ground of distinction. There is also an artificial aristocracy founded on wealth and birth, without either virtue or talents. The natural aristocracy I consider as the most precious gift of nature for the instruction, the trusts, and government of society. And indeed, it would have been inconsistent in creation to have formed man for the social state and not to have provided virtue and wisdom enough to manage the concerns of the society. May we not say that that form of government is the best, which provides the most effectually for a pure selection of these natural aristi into the offices of government. The artificial aristocracy, on the other hand, is a mischievous ingredient in government, and provision should be made to prevent its ascendancy. Now let me restate this idea that Jefferson is describing. Imagine that we are setting out to create a just society, similar to the argument in Rawls' famous theory of justice. At least a couple of immediately obviously causes of differences and of potential injustice that we would have to consider include the following. So we're trying to create a just society, and some things are mucking up the works in our attempt to do this. There are two possible things of that kind. One might be a natural lottery, which assigns people the natural assets to which they are born. And one might be the social lottery, which assigns people their social position at birth. And the natural lottery assigns people these natural assets with which they are born, and these assets affect their life chances, just like the social lottery does. And the social lottery is the way in which one's initial position, your family or your class, affects your opportunities in life. It affects how people of similar talents and abilities, as specified by the natural lottery, perform. Now, the important thing to realize is that both lotteries affect your life chances. But because the amount of resources in any system is finite, more advantaged groups will always command more resources than less advantaged groups, or even exploit the other groups. In other words, if some inequality is intrinsically biological, people are born with different talents, different virtues, different abilities. If there's any natural lottery at all, which we know there is, it can be reinforced by the existence of complex social systems that necessarily involve hierarchy, operating under a budget constraint. So the idea is there's only so much of the good stuff in life or in the world. And so if some people are stronger or brighter or more virtuous or have other talents that allow them to claim more of that stuff, because there's only so much of it, you're going to have a reinforcement whereby the rich get richer and the poor get poorer. And this reinforcement can be abetted by a kind of social lottery, which reinforces a kind of hierarchy. So the social lottery can kind of add on to the workings of the natural lottery. The presence of a budget constraint is crucial, because if there were infinite resources, we wouldn't care. But the fact that there aren't infinite resources and that there's only so much good stuff that can go around means we must care if we care about justice. So we might quite rightly wish to constrain or countermand the operation of the social lottery in the name of justice. And we might even want to provide for a social counterbalance to the natural lottery. So the idea here is there's something about the social lottery which strikes us as unjust. We can discuss that if you want. We probably will discuss that. The natural lottery is a bit more complicated, but what we certainly don't want if we want a just society is to have a kind of who you are in your life chances to be affected by circumstances of birth. You're born into a rich family or a poor family, that has a very big difference on your life chances. Now, interestingly, Jefferson had given thought to this as well, identifying at least one way to deal with a social lottery. So here's what he said in another letter to Adams. At the first session of our legislature, after the Declaration of Independence, we passed a law abolishing entails. And this was followed by one abolishing the privilege of primogeniture and dividing the lands of intestates equally among all their children or other representatives. These laws, drawn by myself, is that unbelievable? Laid the axe to the root of pseudo-aristocracy, and had another, which I prepared, been adopted by the legislature, our work would have been complete. What's the law that Jefferson didn't pass? Listen to this. It was a bill for the more general diffusion of learning. This proposed to divide every county into wards of 5 or 6 miles square, like your townships here in New England, to establish in each ward a free school for reading, writing, and common arithmetic, to provide for the annual selection of the best subjects from these schools who might receive at the public expense a higher degree of education at a district school, and from these district schools to select a certain number of the most promising subjects to be completed at a university, where all the useful sciences should be taught. Worth and genius would thus have been sought out from every condition of life and completely prepared by education for defeating the competition of wealth and birth for public trusts. It's just unbelievable, actually, this man's intellect and what he thought of. he realized something which we still don't understand in our society, that a free education, a good one, for everyone, is a way to compensate for the social lottery. And then we can compensate for the natural lottery by intervening in the social lottery. Now, when we observe worse wealth health, for example, so now, and doing this provides us one path towards having a just society. Now, when we observe worse health, for example, in minority groups, surely most, if not all of this, is due to the social lottery, which seems manifestly unjust. But we also have to be mindful of the distinction between unequal outcomes versus unequal treatment. So just because there's inequality out there doesn't mean it's unjust. For example, if it's the workings of the natural lottery, there may be nothing we can do about that. Someone is born blind, for example. That's the working of the natural lottery. It's not unjust from a social point of view, maybe unjust from another point of view. So if we see racial differences, for example, in our society, what does it mean, and do we care? Now, if we see a difference between racial groups, according to the Institute of Medicine, before we judge it to be problematic and potentially unjust, we need to do the following things. We need, first of all, the claim goes, to adjust for other attributes. So we see differences across racial categories. Well, maybe it's just differences due to class or socioeconomic status. So it's really not race that's salient or important, it's SES. We need to consider insurance status. Maybe the problem is not that you're black or white. Maybe the problem is that if you're black, let's say, you're less likely to have insurance. We need to consider comorbid conditions. So if there's, different health outcomes in different groups, maybe it's due to the natural lottery. Maybe blacks have a higher risk than whites for certain conditions, or vice versa. So it's nothing to do with society or social injustice. And we also have to consider differences in disease severity or stage across groups. And we also have to attend to certain methodological features. If we're going to look at evidence, if someone comes to you and says, look, blacks and whites or Native Americans and blacks and Hispanics or whatever groups there are differ according to some aspect, we need to consider some methodologic features before we conclude that this is a robust observation. We need to understand, have they used good clinical data? Do they have prospective data collection? Have the studies been done in a prospective fashion across time, beginning now and following the people forward? Is there some objective standard for appropriateness? This is an important idea. Just because we see differences, and I'll come back to this in a minute, between, let's say, two groups, let's say you see whites get more of something than blacks do, well, maybe the more of that thing, maybe it's bad for you. So we're not doing the blacks any favor if we give them more of that thing, right? In an ideal world, we would want some kind of a standard or objective standard of appropriateness, and we also need to account for patient preferences. Maybe people with different ethnic backgrounds have different desires on average, and that may explain some of the differences. Now, whether you think that some or all of these are important also depends in part on your conceptual model of how race works. So there's abundant evidence that once you control for socioeconomic status, racial differences in health status substantially decline or disappear. But the problem is, what does this mean? And it depends on your perspective about what you think is going on, about how you think race might be working to affect health. And this can happen in at least two ways, as shown here. Now, in the top, both race and education have some independent effects on health. So something about your race affects your health status, and something else about your education affects your health status. And if you want to get a pure estimate of the effect of race, if you're trying to say, well, to what extent does race account for health status, you want to control for or adjust for education. And if we control for education and the race effect disappears, after taking into account people's different groups, different educational levels, we no longer see an association between race and health. If that's what happens, the race disappears, it means that race has no independent effect. It means that we were falsely thinking that race had something to do with what we were observing, whereas actually there's some other thing, namely education, that's actually driving this effect, or this relationship. However, if your causal model is not like the top, but like the bottom, whereby you have race that changes the level of education you have, and that changing of level of education then changes the health outcome that you have. In the bottom, race leads to poor education. So if you control for education, it effaces the effect in a potentially misleading way. Here, race is actually still causal, but we've made it disappear for the wrong reasons, okay? So if, as known to God, this is what's happening in the world, controlling for education here is a good thing because it allows us to isolate and determine, does race affect health? But here, if as known to God, what happens is your racial background determines what education you have, determines whether or not we are adhering to the Jeffersonian ideal or not, and that then in turn affects your health. Once you adjust for education, the race effect disappears here, just as it did here, but now for the wrong reasons. Now you cannot say that race has no effect on health. What you can say is the way race affects health is via the effect on education. Do you understand? Here, when controlling for education makes the race effect disappear, we can say race has no effect on health. Here, if this is what's actually happening, we can't say that. What's happening here is that race causes education, and education then causes health. And again, in both cases, controlling for education will typically reduce the impact of race, at least in this application. And this in turn affects what we think about the causal status of race. In the bottom, giving everyone a free and good education will, quote, solve the, quote, problem of race. Whereas in the top, race might still have its own effect, even if you gave everyone a free education. And I do not want to overdo the correspondence, but in the top, race is part of the natural lottery, and in the bottom, race is part of the social lottery. Being born of a particular race determines your life chances for reasons that have got nothing to do with you, but rather to do with the structure or the society around you. Now, before proceeding, I need to say that it can be very hard to talk about race, even still in our society. And the reason is that on the one hand, it shouldn't matter, right? In a kind of an ideal world, our racial background should have no bearing on our chances in life, on how we treat each other, and how we interact. And so therefore, talking about it kind of reifies race and privileges it and reinforces its importance so that perhaps wrongly you will leave this class thinking that race is a crucial factor or determinative or somehow so essential that we cannot or should not ignore it. And in fact, there are quite a number of reasons not to talk about race. And these include the fact that when you talk about it, you might overstate the role of race as reflecting genetic or biological differences between populations, which in fact are very few. There are some, but they're few. Or it may fail to reflect the fluid and dynamic nature of sociopolitical identity. You know, is Barack Obama black or white? Well, he's considered to be black, but really why exactly? You know, the so-called one-drop rule and all this other history we have in our society. And it fails to reflect the way many Americans choose to define themselves. One of the least consistent variables, like if you ask people every 10 years on the American census what your sex is, people tend to have the same sex every 10 years. But if you ask them what their race is, actually people change their racial self-identity. So this is another reason not to privilege race. So for all these reasons, we might say, well, why are we talking about this? On the other hand, it does seem to matter. And so actually not talking about the manifest racial differences in our society when it comes to health status could appear ignorant or worse, irresponsible. So we're going to spend the day today trying to understand the nature of racial differences in our society and some of the origins of these racial differences. But I don't want you leaving today thinking that, you know, race ought to be like a really important feature of our society. I certainly have the fantasy that, like Martin Luther King said, that, you know, one day we'll be judged by the content of our character and not the color of our skin. Okay, so returning to the present situation, this slide shows the effect of adjustment for level of education, like we were talking about, on the disparity in potential life years lost between black people and white people according to the specific cause of death. And so here on the y-axis is the racial disparity in potential life years lost, and here on the x-axis are different conditions. And this shows, for example, how much more likely blacks are to lose life due to cardiovascular disease, and here due to cancer, and here due to infection. So for most of these conditions, blacks are at greater risk than whites. And then right next to the ones with the black dots are little white dots, which adjust for age and sex and also education. So what happens when you adjust for the education differences between blacks and whites? What happens to the disparity between blacks and whites in these various conditions? And as you can see, in all the cases it decreases. So the white dot is, except for this rheumatologic condition, the white dot is lower than and to the right than the black dot after you adjust for education, coming near to the no difference line. And in fact, the confidence intervals for many of these, but not all of them, include the no difference line. For example, you might say blacks are more likely to lose years of life due to cancer than whites, but after we adjust for education, there's no difference between blacks and whites in the burden of cancer in those populations. In cardiovascular disease, there's a difference, but after you adjust for education, it's less of a difference, and so forth and so on as you look across the data. Note that adjusting for education decreases the black-white difference and eliminates in cardiovascular disease and eliminates the difference in cancer. And whether you think this solves the issue of race depends on your causal model. So, in all cases, controlling for education reduces the difference, but you still don't know what's going on just by doing this analysis. You don't know, is it that race and education are independently affecting health status, in which case you want to control for it in order to make a pure statement about do blacks differ than whites, for instance, in this attribute, or is controlling for it the wrong thing? Have you done yourself a disservice because now controlling for it, you think, oh, well, there's not such a big problem. After you control for education, there's no longer an effect. So blacks have no difference than whites after you control for education. But if this is the model, actually the way your race increases your risk of cancer is by giving you a worse education. Controlling for it and then coming to the false conclusion that there's not a problem is the wrong thing to do. People understand what I'm saying? Okay. Well, let's get a handle on black-white differences in the use of medical procedures. Here are some data based on a review of large samples of patients' administrative records. So if you look at black-white differences in procedure use among Medicare beneficiaries using enormous samples, so here are the rates, the relative rates, procedures per thousand for various procedures. This is a kind of procedure where a little balloon is threaded through your coronary artery to open up blocked arteries. Blacks are much less likely, more than half as likely to get them as whites. They're less than half as likely to get coronary bypass surgery. They're almost half as likely to get mammography. They're less likely to have their hip fracture repaired, but they're more likely to have their limbs taken off or the testicles removed. So you look at something like this and you think, whoa, wait a minute. What could be causing this in our society? And it begs this very profound, in my judgment, set of questions. These differences may, in fact, reflect complex mixes of disease prevalence. Maybe, for example, the removal of testicles is a legitimate procedure for people with prostate cancer. If rates of prostate cancer were 2 or 3 times higher in blacks than whites, then this thing wouldn't necessarily be a problem. Or removing of limbs is a common problem for diabetes. If diabetes is 2 or 3 times more common in blacks than whites, maybe limb removal is not an inappropriate thing. So these differences, these crude differences, could reflect complex mixes of disease prevalence, patient preferences, and the workings of the healthcare system. Certainly, many African Americans perceive a difference in access to care, and whites do so to a lesser extent. This slide shows data regarding the answer to the following question. So a sample of Americans were asked, do you think the average African American is better off, worse off, or just about as well off as the average white person in terms of access to health care? And so when blacks are asked this question, when whites are asked this question, you get this distribution. So most whites think that blacks are just the same off as everyone else. Some, 35%, acknowledge that they might be worse off, and then these other tails. When you ask African Americans, however, you get a very different distributions. So about 60% of African Americans think they are worse off when it comes to access to health care. Now, on the other hand, some work on the extent to which race determines the use of teaching hospitals finds that African Americans have higher than expected use of teaching hospitals or higher access. So this is another little quirky footnote. Most of the time, our elite teaching hospitals in this country are considered to be the best hospitals in the country. And usually, African Americans are disproportionate users of these hospitals. Now, typically, it's because the hospitals tend to be located in places in Philadelphia, here in Boston, used to be near in Philadelphia, near West Philly, in University of Chicago, in the south side of Chicago, in Johns Hopkins, in the part of Baltimore that had a high African American population, here in Boston, near Roxbury. It's not a coincidence. There are certain reasons why this happened, actually, historically. But whatever the reasons, it is the case, actually, that many African Americans, certainly urban African Americans, are bigger users of teaching hospitals than you might think. So maybe it's a bit more complicated here again. Maybe, in fact, by other metrics, you have not the picture that's shown here. And most importantly, just because there are differences doesn't mean they're problematic. There are several sources of difference, only some of which we might regard as problematic. And these include, so if we see differences between blacks and whites or other ethnic groups when it comes to healthcare use or health status, What might be some difference, ways, explanations for this difference? Well, there could be patient-level factors, patient preferences, refusal of treatment, poor adherence to medication, or biological differences between groups. There could be health systems level factors, financing issues, structure of care problems, cultural and linguistic barriers. You know, if you've immigrated from Cambodia or Morocco and you need health care at the Mass General, when I was a house officer, it was hard to find someone who could speak your language. Now we just pick up AT&T, translate, and we can do that automatically. Or doctor level factors, disparities that arise from the actual clinical encounter. And we saw last time that sometimes low socioeconomic status can be associated with poor adherence or a patient-level choice in some sense. So last time we saw that people in lower socioeconomic status might be less able to follow instructions. If they're given the right instructions but don't follow them, is it really a fault of the healthcare system, is the argument. So actually, it looks like this. If you look at the quality of healthcare or some health status, not healthcare, if you look either at the quality of healthcare or some measures of health status, disease incidence or whatever, and you observe that this is the level in the non-minority population and this is the level in the minority population, and you observe this difference. There are numerous causes of this difference. Part of it could be due to clinical appropriateness and need or patient preferences. Part of it could be the operation of the healthcare system and legal and regulatory climate. And part of it could be frank provider discrimination, of which there are three types: bias, stereotyping, and uncertainty. And it's only these which might be deemed to be a disparity. So this is just a difference, but there's something about these which we might consider to be reflect a disparate delivery of healthcare. And also it's worth noting that sometimes whites receive more services, perhaps even for bad reasons, but they actually wind up being harmed by this and are decidedly not better off as a result. And this is not to excuse any prejudice, it's just to say that it may be a good thing in some studies to have an objective standard of appropriateness rather than merely looking at black-white differences. We will have done minorities no favors if we roll out to them ineffective or dangerous forms of medical care, and I'll give you examples in just a moment. Well, let's look at the idea that minorities' preferences regarding care might play a part in part of this difference. This is a study from your reading, 800 subjects older than 65 who self-identified in various ethnic and racial groups. They were African American, European American, Korean American, or Mexican American, were asked their preferences with respect to various aspects of medical care. And this slide shows the percentages of each of those ethnic groups who think that a physician should inform the patient that they have cancer, the diagnosis, and that they would probably die, the prognosis. So if you ask African American patients, almost all of them, 90%, think that the patient should be told the diagnosis, and some large number, 65%, thinks that they should be told the prognosis. And there's not much difference between blacks and whites in these numbers. On the other hand, Korean American patients have a very different idea about this. So approximately half Korean Americans think the patient should be told their diagnosis, and less than half their prognosis. And Mexican Americans are different yet again, on average, compared to the other groups. And the same reading showed that there was ethnic variation regarding beliefs about whether the decision to put a patient on a life support machine should be made by the patient, the physician, the family, or someone else. And in fact, it's often the case that on average, African Americans, for example, have an increased taste relative to whites for ICU care and a decreased taste for hospice care, for example. So if you survey African Americans and you ask them, what are your attitudes towards hospice care at the end of life? On average, they want it less. So then if you go out and you measure hospice care and you see that there's a big difference between the use of the two, it doesn't mean that the system is denying African Americans access to hospice care. On the other hand, if you ask African Americans on average and they have a higher interest in ICU care, and you find no difference in rates between whites and blacks, it means the system may be preventing them from realizing that the objectives that they want. But there can also be discrimination by providers, which in turn may be divided into three further types. Now there's bias. Bias is a prejudicial way of treating minority groups with lower regard than non-minorities by virtue of holding these negative views, okay? So you're frankly biased. There's stereotyping, which is a cognitive heuristic or judgment based on group membership without a necessarily negative intent. For example, minorities are less likely to comply with treatment, or minorities prefer expensive invasive treatment, or minorities are less likely to be interested in hospice care, something I've experienced in my own clinical care. Talk to patients from the Arab world or from the Mediterranean or African Americans. They're less interested in having hospice care at the end of life. I had countless conversations like this. Or uncertainty, which is the difficulty in interpreting symptoms in one group compared to another. So these are three sorts of things that might work at the level of physicians, which might differentially contribute to disparity and to the care that's offered to patients above and beyond their own differences, which we might respect and wouldn't necessarily see as sources of injustice. So if patients want these outcomes, we don't see that as unjust necessarily. But if the doctors don't provide, or the healthcare system doesn't provide this access, we would see it as unjust. Now, stereotypes, according to social psychologists, refer to the process by which people use social categories in acquiring, processing, and recalling information about others. And in practice, in fact, it can be very difficult to distinguish from bias. Well, let's flesh this out a little bit more. Okay, so these are histograms of illness severity with cut points indicating when the doctor would choose to treat the patient at a fixed level of severity, in this case resulting in the treatment of more whites. So for example, let's say this histogram here defines the variation in illness severity for a condition in blacks. So some blacks have this severity, not so much. Some have this high severity. On average, they have this level of severity. That's where the distribution peaks. But for whatever reason, this illness creates this distribution in whites. Now, a doctor who's not biased might just set a cut point. Say, if you are in my office, whether you're black or white, if your illness severity is more than X, I will treat you, period. And if you act that way in this situation, you're going to find that more whites than blacks are being treated. That doesn't mean that the doctor is biased, okay? All he's done or she's done is set a cut point and then decided that people who are sicker than that derive more benefit than the cost from the treatment. So a benevolent doctor with complete information treats only those patients, and all of them, who would derive a positive benefit from treatment. And Balsa and McGuire, in their review of this topic, evaluate the occurrence of these three types of discrimination that we've been talking about, and they've evaluate the prevalence of these three types of disparity and discrimination across a number of studies that they and others have been conducted. So here's what a benevolent doctor looks like, but here's what a biased doctor looks like. A biased doctor, facing a situation in which blacks and whites have the same severity distribution, has a lower threshold for treating whites and a higher threshold for treating blacks. This is bias, okay? So you say, okay, patients that come to my office have the same distribution, but if you're white, I treat you very easily. If you're black, you need to be sicker before I treat you. This too will lead to a disparity in the rates of individuals getting treatment between blacks and white, but now it's not due to a difference in the underlying distribution of the severity or some patient preferences or anything else. Now this is due to frank bias on the part of the doctor. But a confused or uncertain doctor makes mistakes, but he doesn't mean to. For example, if the symptoms in minorities are a less reliable indicator of the existence or the severity of disease, there could be miscommunication between patients and doctors will assign treatment to minorities with error. And this is also known as the problem of uncertainty, and it can contribute to discrimination. In this situation, there's more dispersion in blacks in their symptoms given a particular disease, with a flatter distribution, with more at the top and at the bottom, even with the same mean. And given this increased uncertainty, the doctor may set a higher threshold for treatment if symptoms in a minority patient are less likely to be indicative of a disease. So what happens here is blacks and whites have the same mean, but the whites distribution is more peaked, and the black distribution is flatter. So there's more dispersion around the mean in the black. So the doctor is more easily confused, doesn't know what's going on when he sees this patient. Could be evidence of disease, could not. And for this reason, might rationally set the standard for blacks higher. This isn't because he's biased, although he could be. This is because he or she is uncertain. So symptom severity this is the symptoms and severity in patients given that they have a particular disease. So I can summarize some of the work McGuire and his colleagues have done in this area as follows. They conclude that evidence for bias, so when it comes to bias, there's limited evidence, but patients do report the experience of discrimination. Stereotyping, there's evidence that suggests that physicians do use these cognitive shortcuts. So physicians form sort of Bayesian probabilities. They form certain ideas about the probability of a condition. And I'll show you an example in just a moment, of people, and they used race and ethnic categories as a kind of cognitive shortcut without ill intent. There's evidence for that. And finally, regarding uncertainty, evidence suggests that doctors use race in a probabilistic way to make diagnoses and implement treatments, or a kind of statistical discrimination. So if I know that prostate cancer is more common in blacks than whites, it just is that way, for whatever reason, the natural lottery or the social lottery, at this point, I'm just a doctor, the patient comes in, a black person complaining of a certain set of symptoms would be more likely to prompt me to order some tests than a white person presenting with the same symptoms. Here I'm just using, a kind of a cognitive heuristic to help me decide how to allocate my treatment. So, so it's complicated, right? I mean, the problem is that there is racial bias in the healthcare system, but not all of the differences are disparities, and not all of the disparities reflect bias. And so when we speak of bias, we want to be very careful to hone in on exactly the extent and nature of the problem, rather than focusing, as it were, on the whole thing and misconstruing the nature of the problem. Because, of course, no doubt there is discrimination in our society and in our healthcare system, and it can harm people's health outcomes. One of the best studies in this area was done by epidemiologist Diane Lauderdale, in my judgment, and is in your readings. So she studied a sample of all babies born in California in the 6 months after 9/11 compared to the same 6 months period the year before. And she computed a ratio of risk of low birth weight in the two periods in each ethnic group. So she said, you're a white woman delivering a baby in October of 2001, after 9/11. What's your risk of having a low birth weight baby compared to being a white woman delivering a baby in October of 2000, a year earlier? And she did that for whites and for blacks and for Arab Americans and for every ethnic group, for a variety of ethnic groups. She did this little computation. And she found no change in any of the groups except in Arab Americans. So for example, if she looked at the relative risk of all women of having a low birth weight baby, among all women the risk is the same. So there's no secular difference. It's not like across time low birth weight had been increasing dramatically, so therefore a 1-year difference led to some increase just because of change in time. That was not the case. She looked at all foreign-born women, no difference if you looked at that category. Non-Hispanic whites, no difference. 9/11 didn't, if you're a pregnant woman during 9/11 compared to a pregnant woman a year before, it didn't affect whether your baby would be born small. Non-Hispanic black, no difference. Asian and Pacific Islander, no difference. Native American, no difference. Hispanic, no difference. But if you have an Arabic last name, your risk of having a low birth weight baby went up by 34% after 9/11. So if you were an Arab woman pregnant with a baby during 9/11, the probability that your baby would be smaller compared to if you were an Arab woman a year earlier goes up significantly. And if you're, look at how clever she was, Diane Lauderdale, in this study. So she said, well, how could I use these birth certificate data to try to make an inference about whether really this had something to do with the way the woman was being treated or the way she felt about herself in society after 9/11? Well, maybe we can use as a proxy for women that are more likely to be manifestly Arab, more traditional perhaps in their attire or their comportment, or affected more by these events. Let's use as a proxy whether the infant's given name was ethnically distinctive or not. And if the infant's given name was very ethnically distinctive, such women had more than twice the risk of having a low birth weight baby, Arab women, after 9/11 than before. And there was also an increase even amongst the women whose babies did not have an ethnically distinctive name. Is that clear? So, this is very nice, in my judgment, powerful. We can't randomly assign people to be treated in a discriminatory fashion, right? We can't take a group of pregnant women and say, you guys, doctors are going to treat you horribly, and you guys, you're going to just be treated just fine, and then we come back and weigh your babies in 9 months. So we have to use observational data, but this is one of a very clever design that Diane was able to do, and it suggests strongly, in my judgment, that Arab American women were discriminated against in our society after 9/11 in a way that affected themselves, their bodies, and actually their babies. Well, what are some other ways we can explore whether doctors discriminate, whether due to bias, stereotyping, or uncertainty? Here's another study. So you could ask people, do you discriminate? So I ask you guys, raise your hands if you have racial prejudices in your mind. Okay, yeah, some of you. So some of you probably taken Mazhar Banaji's class and are not ashamed to admit that. So all of you do, actually. But most people wouldn't just admit to it if you asked them to raise their hands. It doesn't matter, incidentally, whether you're minority or non-minority. Pretty much everyone has a certain set of prejudices. It's what you do, it's whether you act on your prejudices that really matters, in my judgment. So if you ask people if they discriminate, whether due to bias or prejudice, most people would say no. But you can do an experiment to test whether they feel this way or not. These are photos that accompanied an experiment involving 720 physicians who watched a video of an actor describing some chest pain symptoms. But different actors were shown with the same story. So the doctor is listening to a patient on a video describe an experience. But there were 4 different actors, these are the 4 actors, who told the same story. You had a kind of middle-aged woman, white woman, and a middle-aged white man, and an older white woman, and an older white man. And they're all like in this same little doctor's little, set, and they're telling a story about their chest pain. And after they watched the video, the physicians were asked to do a bunch of things with respect, or asked a bunch of hypothetical questions about how they would treat these patients. And one was to estimate the likelihood that the patient actually had coronary artery disease. Now, if you watch this video, you've had no medical training whatsoever, and a patient said to you, well, I have some chest pain, and it feels like this, and starts this way, and so forth, would you be more likely, if you were told the story by this person, to think it was coronary artery disease, or by this person? Raise your hands if you would think this person is more likely to have it. Raise your hands if you think this person is more likely to have it. Okay, well, the correct answer is this guy, because he's older, okay? Older people are just more likely to have coronary artery disease. It's not bias or discrimination, it's just a fact. So if someone tells you a story that they have chest pain, you'd be more likely to think. Now, what about whether if you were told the story by this person or this person? So the woman tells you the same story, or the man. Now who do you think is more likely? Do you think a woman, with this story, the woman is more likely to have coronary artery disease, or the man? Yeah. So on average, there's a slight, it's not 100%, but men are slightly more likely, given the same story, to have coronary artery disease. Actually, not given the same story, just more likely overall. So the physicians were shown these videos, and they were shown these videos, and then they were asked to estimate the probability that a patient had coronary artery disease. It's not irrational to assign different probabilities to different ones of these categories. Then, and in fact, the physicians' estimates of the probability of coronary artery disease varied by sex and age and the history of the patients. But the pattern of these differences were consistent with the known prevalence of coronary artery disease in various groups of patients, just like you've demonstrated now. But then what happened in the video was that a test was performed to confirm the presence of coronary artery disease, and this test was then given to the doctor that was watching this video. And then they were asked, would you perform a catheterization? There were actually another 4 actors. There were a total of 8 different actors. They were otherwise the same as everyone else, but now we have the black faces here. And these women and men, they told the same story as the people on the previous slide. So the doctors estimated the probability of coronary artery disease, and after they estimated the probability, then they said, okay, now we did the test and we confirmed the patient has it. Would you order a catheterization for the patient? Now, if there's a difference between groups, it's hard to imagine what it could be due to other than some kind of working or bias in these doctors in the situation. Now, keep in mind, each doctor only saw one photograph. So I don't know that there is even a different race or gender or age of anyone else. I'm just saying, here's what I would do, and we have a group of doctors that sees the upper left photograph, a different group that sees the upper right, and so on and so forth. And then if we compare the answers to the probability that you would order a medical procedure across these groups, it can only be due to the fact that you were shown a different picture and not to anything else, right? We've done an experiment. We've randomly assigned you a different age, sex, and race of the subjects, and then look to see, does the race of the patient influence the care that you offer? And here are the key results. So this is the mean referral rate for catheterization. Men are slightly more likely than women to be referred for catheterization, and whites are slightly more likely than blacks to be referred for catheterization. even given the fact that the doctors were told the patient did have coronary artery disease. So this is the kind of study we can do then to see, is there evidence that there is some discriminatory working, some bias in the workings of the healthcare system. Are there any questions about this? Yeah. Yes, but then we tell them the test result. We say, yes, they do have it. So now we're at a group of people where we have confirmed that you understand? So then we tell them the test result, and then we ask them, would you do the next thing? So first we elicit from the doctors, and they're good, the doctors. They accurately report the probability that the patients will have coronary disease based on these heuristics, which aren't biased. Then we say, what would you do next? You see, that's why the study was done this way. Yeah, another question? I don't remember if it's in the study. Often when you look at the doctor's race, it doesn't really affect the behavior, actually, which is interesting. Actually, we have something I want to show you on this point. We'll come to that. All right, let's come to that. So let's turn to an interesting set of findings also from your readings, actually sort of related to the point that was just mentioned. These investigators looked at the healthcare use of millions of patients spread over 79 broad geographic regions in the United States. And the conclusion in the study that you read is that the large racial differences in surgery are often the result of high white rates rather than low black rates when judged by external standards of appropriateness. Moreover, the differences in healthcare are driven more by residence than by race. These investigators found that a region with small racial disparities in one procedure is just as likely to have a high disparity in another procedure. Listen to that claim. So we see, oh, there are big racial differences in this procedure. Must be discrimination. Well, look at the next procedure, opposite ratio. So it can't be discrimination. If you see across procedures lots of differences, that's observational evidence that that's not the working of a discriminatory system in that situation. This type of evidence would subvert the idea that there's some kind of systematic prejudice on the part of doctors, because we don't think doctors might discriminate or be prejudiced against groups of patients when it comes to this procedure, but not this other procedure. If they're prejudiced, they should probably be consistently prejudiced against people of a certain ethnic background, not specific to the procedure that's being given. More generally, and I'll review the slide with you in just a moment, average disparities are driven by the fact that blacks tend to live disproportionately in regions of low overall rates for both blacks and whites. So equalizing rates within regions would not reduce disparities at a national level. Moreover, as shown on this slide regarding a simple and important test in diabetics, which is the hemoglobin A1C test, regions with the smallest racial disparities are not necessarily the ones providing the best available care to blacks. For example, look at Washington, D.C., which is shown here. So here on the y-axis we have percent of blacks having a hemoglobin A1C test, and on the x-axis we have the percent of whites. The diagonal line means that the blacks and whites are receiving this test at the same rates. So it's the line of no disparity. There's no difference between blacks and whites along this line. Here, in this situation, there's a big disparity between blacks and whites. Oh, and so here is the zone where whites have more of the test ordered, and here is the zone where blacks have more of the test ordered. So here's some cities where blacks are more likely than whites to get hemoglobin A1C level drawn, but in most of the cities, whites are more likely to have the test ordered. Everyone with me still? And here, the disparity in Washington, D.C. is very significant, 14% point difference. So for example, 75% of whites will have the test compared to whatever it is, 60% of blacks will have this test, okay? Now, in Chicago, there's less of a difference. It's not as far below the line if you look at Chicago, but we wouldn't do the blacks in Washington any favor if we moved them all to Chicago. Because here in Washington, D.C., 60% of the blacks have the test, whereas in Chicago, 45% of the blacks have the test. Does everyone understand this point? So what's happening here is even though there's greater disparity in Washington, it's not necessarily better if you're in the minority group to be in an area of no disparity. And actually what really seems to happen is in areas vary in the extent to which they order the test at all, and blacks tend to live in places where less tests are ordered. Both whites and blacks get less tests in those areas, but blacks tend to live in those geographic areas. So there's more dispersion along the line than up and down. That is, there's more variation in disparities between regions than within regions. Is that clear, that point? Okay. Finally, I would be remiss if I did not alert you to the complexities in studying the relationship of race and ethnicity on health. For example, there's something known as the Hispanic paradox. And this came up last week when we talked about SIDS in the back to sleep example. Because of the composition of by socioeconomic traits, the health and mortality profile in Hispanics would be expected to resemble African Americans more closely than non-Hispanic whites. But it does not. So it's a paradox in that the expectation is not consistent with the observation. And there's Hispanic, and so this shows life expectancy by age. And so up here we have foreign-born other Hispanics, foreign-born Mexicans, and non-Hispanic whites. So the Hispanics, in both of these groups, do better, have longer life expectancy than whites at every age in this population. And there's a similar Hispanic paradox in most domains: birth weight, infant mortality, adult mortality, and late adult health. And there are two hypotheses regarding the origins of the Hispanic paradox. One is the so-called healthy migrant effect. So Hispanic migrants are selected from origin populations for certain traits, including better physical and psychological health. It's very difficult to come into this country illegally. It requires a lot, or legally, it requires a lot of physical and mental fitness to do so. Or it could be something known as the salmon bias effect. You know, salmon return to the river where they were born in order to die. Migrants from some Hispanic subgroups may return to their country of origin following a period of temporary unemployment and or illness in the United States. So here the idea is that what's happening is the sick Hispanics are being withdrawn from the sample and going home to die. So we don't observe those deaths. Probably the Hispanic paradox is due to some combination of both of these factors. So, to sum up, in studying race, we've seen that various types of factors can account for health disparities. When we are studying the effect of various socioeconomic factors in health, we want to be able to focus on both the individual and their agency, but we want to focus on the structure as well. And we want to avoid, however, a cognitive and moral trap. The study of why some people swim well and others drown when they are tossed into the water, doing that displaces study of who is tossing whom into the water and what else might be in the water. So by focusing so much on whether blacks or whites have this, or other ethnic groups have this or that health status, it may remove us from studying a more deeper and fundamental question, which is, what's the cause of that? Who might be throwing who into the water? Compared to a man sitting safely in a boat, is this man experiencing an unequal outcome, or is he the victim of unequal treatment? See you next time. The slides are being posted now. They're on the course website. The last 5 lectures are already up.